And without further ado, patient-centered care, colorectal cancer, epidemiology, risk factors, and screening strategies. And our presenter is Lisa M. Gangarosa, MD. And I want to give you top 5 that she has shared with us. She is the medical director of UNC-GI procedure at unit at Metamont. And she was the recipient of the UNC Gastroenterology Fellows Award for Excellence in Mentoring in 2013. She was the recipient of the Eugene Boyzymski MD Award for Excellence in the Teaching of Endoscopy, presented by the UNC-GI Fellows in 2008 and 2015. She served as chair, American Gastroenterological Association Government Relations Committee from 2018 to 2021. And finally, she served as president of the North Carolina Society of Gastroenterology from 2016 to 2018. Dr. Gangarosa, welcome. That's an impressive set of awards and credentials.
Thank you so much, Tim. Pleasure to be here.
We always ask our presenters to share something from their personal life, interest, hobby, etc. And you gave me a little preview telling me about yours. You want to share what that is?
Sure. I started doing aerial dance in 2010. That was when one of my younger daughters was interested in circus arts. And after our first class, she's like, well, I don't know about this, but I found it to be just incredible for strength and flexibility. I don't have a dance or gymnastics background, but through the years, I've met a lot of great people. And yeah, I guess I now have a dance background. So it's a great physical activity.
Good for you. We always love hearing about our clinicians' other interests, from rap to pizza baking to so many other things. So thank you for sharing that one with us. We have a sample poll everywhere question. The question is a true-false one. Colorectal cancer starts in the colon or the rectum. And while you're thinking about that for our audience, while the audience is thinking about that, I'll flash up our disclaimers very quickly. And there's the question for real. Colorectal cancer starts in the colon or the rectum, true or false? And Dr. Gangarosa will give folks about 20 seconds to respond to that. And again, just a reminder for our audience, we'll have several of these poll everywhere questions. They're all anonymous, so go ahead and take your best shot at those. And then Dr. Gangarosa, how are they doing?
Well, there's a few people who said false, and unfortunately that is not correct. Yeah, colorectal cancer is either in the colon or the rectum as the site of origin.
All right, very good. Well, not good, but good on the audience for primarily getting that one correct. And colorectal cancer, epidemiology, risk factors, and screening strategies. I'll let you go ahead and take it away from here.
Welcome, everyone, and I hope this lunch hour will be educational for everyone. I have no disclosures. And here's the first poll everywhere question. So these are scattered throughout the talk, and as we go through the slides, the correct answer should become evident. But the first one is, in the United States, roughly how many new cases of colorectal cancer will be diagnosed this year? A, 50,000, B, 100,000, C, 150,000, or D, 200,000? And it looks like we do have a smattering of answers spread somewhat evenly between B, C, and D. So let's continue, and you'll figure out what is correct. The objectives of this lecture are for you to be able to describe epidemiologic trends in colorectal cancer, to describe and differentiate modifiable and non-modifiable risk factors for colorectal cancer, and to list and discuss screening options for colorectal cancer. So we're going to first cover epidemiology. And the most important thing to realize is colorectal cancer is very common. It does have quite a geographical variation in incidence. And you can see that countries in Europe, Australia, Canada, and Uruguay have the highest incidence, followed closely behind by United States, other South American countries, Russia, China. And there's a much lower incidence in the African nations. There is also geographical differences right within the United States. And several of the countries kind of in the Mississippi Delta of the Southeast, as well as Alaska, and some of these more mid-Atlantic, Midwest states have the highest incidence. We here in North Carolina are at the lower end of the spectrum, though not the lowest. Now, in the US last year, the estimated new cases of colon and rectal cancer in men were 81,860, and in women, 71,160. So if you add those together, the correct answer was about 150,000 new cases in the US. You can see that that is both 8% for men and women, and you can see that it's the third most common cancer in both men and women in our country. There are more cases of prostate and lung in men and more cases of breast and lung in women. And that the number in men is about 10,000 higher than in women. Now, luckily, the trends in incident cancer rates in men have been steadily declining, though since 2019, that decline seems to have plateaued. And a similar trend has been seen in women with a decline in incidence. Looking here at this green line. Okay, here's our next poll everywhere question. The average lifetime risk for developing colon cancer in the US is about A, 1%, B, 2%, C, 4%, or D, 8%. Okay, great. It does look like the majority got this one correct. Most recently, in men, the lifetime probability for developing cancer was 1 in 23. And that is just over 4%. And in women, it was 1 in 26, which was just under 4%. Also, a favorable trend is that the cancer death rates since 1930 have declined. And in men, they were fairly steady up until about 1980, but since 1980, they have been steadily declining, which is good news. In women, actually, the decline started earlier, back in about 1950. And we've seen a nice decline in death rates. So in the U.S., the estimated cancer death rates for men is about 28,470, which is 9%, and in women, 24,080 at 8%. Since I'm a gastroenterologist, I'm interested really in all the GI cancers, and you can see, unfortunately, that pancreas cancer is just right behind colon cancer in the number of deaths in both men and women. So estimates for this year, 106,000 colon and 46,000 new rectal cancer cases with about 53,000 deaths. Again, lifetime risk, men 1 in 23, women estimated to be 1 in 25. And unfortunately, 1 in 3 adults aged 50 to 75 are not adhering to the recommended colon cancer screening recommendations, and we'll get more into that a little bit later. Other good news is that 5-year relative survival rates have increased. Treatments for colon cancer, which is not the subject of this test, of this talk, have had increasing success in treating this disease. But unfortunately, we still have disparities in this cancer, and you can see that an absolute difference of 5 between white and black Americans with colon cancer, 2012 to 2018. So we have work to do there. Now, a recently recognized trend is that colon cancer before age 50, which is defined as early onset CRC, has been identified, and it's been especially more common for rectal cancer. And there was a recent paper in Clinical Gastroenterology talking about birth cohort CRC. Now, a birth cohort effect is one that the outcome is strongly determined by your year of birth or birth cohort. And birth cohorts age through life together and share exposures, and they can be experienced differently by different age groups and influenced by time period related exposures. So what we have found is that the incidence of colon cancer is increasing in those born after 1960. And we've seen an increased incidence in people under age 50, people in the 50 to 54 year age range, and that for those 55 to 74, while the incidence may not be going up, it previously was decreasing, and that curve is now flattening. What we've seen is also that there have been an increase in rectal greater than colon diagnoses, an increase in more advanced disease rather than early stage disease, and that the increased incidence is really happening across all racial and ethnic groups of folks under age 50. And so here are some of the different birth cohorts, and you can see that the incidence rate is rising with each kind of younger cohort. And if you compare the different cohorts to those born 1950 to 1954, you can see the following increased incidence rates. So for those born 65 to 69, a 1.22 rate, 75 to 79, 1.58, 80 to 84, 1.89, and those born 1990 to 1994, the incidence rate is 2.98. So like a threefold increase over those born 1950 to 1954. Here are some pie charts showing the age distribution comparing 1992 to 2019. And in 1992, you see that over 50% of cases were over age 70. But in 2019, that has fallen to about 40%. And there's been almost a doubling of those in the 50 to 59 age group. And also increases in those even younger. And then this lower pie chart is by ethnic groups, and you can see that in 1992, 3/4 were non-Hispanic white, but that in 2019, that had declined 58%, with substantial increases in all of these other ethnic groups: Hispanic, non-Hispanic American Indian or Alaska Native, non-Hispanic Black, and even the non-Hispanic Asian or Pacific Islander. So all ethnicities are showing an increased rate. Now here's just the age group of 50 to 59, showing that perhaps the overall rate hasn't changed much, but that the proportion that are rectal cancers is steadily increasing, where the distal colon and the proximal colon are decreasing, and that local disease has decreased, but regionally advanced or distant disease are both increasing. And that, again, pretty much all of the different ethnic groups are increased, except there has been a recent decline in non-Hispanic Black cases in this age group. So there's lots of theories, some of which are going to be, very difficult to tease out, but every patient has like their own genetic background, and then what's kind of called the exposome of all different things that you're exposed to, your diet and your lifestyle, early life exposures, including in utero, medications, including antibiotics, different metabolic disorders, and then the microbiome, which is all of the gut bacteria that live in your colon. Changes in these or how these affect your genetics lead to mutations, and eventually the accumulation of enough mutations leads to colon cancer. So what are some of the risk factors that we do know about for colon cancer? And so here's the next poll everywhere question. Which of the following are risk factors for colon cancer? A, female sex and diverticulosis. B, adolescence and low BMI. C, hyperplastic polyps and high fiber diet. Or D, male sex and smoking. It does look like the majority has gotten this one correct, with male sex and smoking. So here are some of the non-modifiable risk factors for colon cancer. As I mentioned, it is more common in men, and worldwide, men have about a 1.5-fold higher risk. We've talked about that age and birth cohort are risk factors. We previously said that advanced age was a risk factor. But now it seems that, when you were born will be playing a role. Ethnicity. There are clearly hereditary mutations, and hereditary colon cancers account for 7 to 10% of cancers. These include genetic diseases such as familial adenomatous polyposis and Lynch syndrome. If you have long-standing inflammatory bowel disease, such as ulcerative colitis or Crohn's colitis, you have a twofold increased risk, which is more common with ulcerative colitis. If you have a history of prior abdominal or pelvic irradiation, another genetic risk factor that you would not be able to modify is cystic fibrosis, which actually has a 10-fold higher risk of colon cancer. Acromegaly, a history of cholecystectomy, or a history of androgen deprivation therapy. If you use GnRH agonist therapy for 25 months or more, or have a history of orchiectomy, you can see these increased risk ratios. Now, these are some modifiable risk factors, though changing human behavior to modify these can often be quite difficult. But smoking, alcohol consumption, diet, and studies have shown that increased red and processed meat, especially, are risk factors. Diabetes and insulin resistance, your level of physical activity. Studies have shown that the most sedentary have about a 50% increased risk. Obesity, and again, the gut microbiome, though like studies of this are in their infancy, and which microbiome profiles might be more protective versus which might be risk elevated are not clear yet. So here are a couple of recent studies on modifiable risk factors. The first came out of Norway, which in the last 20 years has had a 3-fold increase in colon cancer. And they studied 35,000 women. They collected information in the mid-90s and then followed up, and they asked about smoking status, alcohol consumption, BMI, physical activity, intake of calcium, fiber, red and processed meat. And during the 18.6 years of follow-up, they did have 430 incident cases of colon cancer, and they did not include rectal cancers in this study. And what they found was that smoking was the greatest risk factor, and that they had a 40% increase of colon cancer among current smokers and 39 in former smokers compared to never smokers. And that they felt that the population attributable fraction to either current or former smoking was nearly, 1 in 5. And that 2,400 cases could have been prevented if all women aged 40 to 75 were never smokers. So again, when you're seeing patients, one of the most important things you can do is, talk to them about smoking cessation. The only other risk factor that was statistically significant was that a high level of physical activity was inversely associated with the risk. And they felt that the proportion of colon cancer cases attributable to low physical activity was 10%. None of the other items were statistically significant. And then in this other study on non-genetic determinants of risk, the data was pulled from 13 population-based studies that restricted the populations to genetically defined European descent. Again, self-reported information. These studies were done in the 1990s through the 2010s. And what they found in their multivariable models was that early onset colon cancer was associated with not regularly using NSAIDs, greater red meat intake, lower educational attainment, and interestingly, both complete alcohol abstinence or heavy alcohol use. And all of these, have odds ratios of less than 2. So, they are risks associated with it, but how meaningful or how much of an impact, unclear. What they also found was that none of these factors exhibited a greater excess in early onset compared with late onset. So these are risk factors for colon cancer no matter what age. And then when they looked at anatomic subset, they did find that a low fiber intake was linked more strongly to rectal cancer than more proximal colon cancers. In terms of birth cohort effects for comorbidities, as compared to people born in the 1940s, obesity and type 2 diabetes are increasingly prevalent in those born in subsequent decades. And obesity has been found to be a risk factor in many early onset cancer studies. In one meta-analysis, the odds ratio was 1.88 for those under age 55 with a BMI greater than 30. And similarly, type 2 diabetes had an odds ratio of about 1.6. So now we're going to turn over to screening strategies. And which of the following is not currently recommended colon cancer screening option by at least one major organization? A, Q2-year FIT testing, B, Q3-year blood DNA, C, Q3-year stool DNA FIT, or D, Q10-year colonoscopy. Again, which one is not currently recommended? All right, well, it looks like we got a split kind of between the Q3-year blood DNA and the Q3-year stool DNA FIT. So let's look at some of these strategies. So first of all, when you're talking about screening for any kind of cancer, the screening program is going to target what we call asymptomatic individuals. They should have no signs or symptoms of a disease. So if a patient has anemia or a patient is telling you they're seeing blood in their stool, they're going to be sent for diagnostic studies. They're already out of the screening algorithm. In screening strategies, once an individual has a positive screening test, they usually undergo additional testing and treatment. If an individual has a negative test, they usually do need to be rescreened at regular intervals. And there are actually 2 types of cancer screening tests: early detection screening and preventive screening. And early detection screening tests must reduce mortality compared to no screening. Now, most somatic colorectal cancers, meaning not part of one of the genetic syndromes, is the result of accumulation of mutations. And this sort of progression was first published by Fearon and Vogelstein in 1990, where they found that when you started losing certain genes or having mutations with gain of function, that you went from normal mucosa to early adenomatous polyps to then more advanced adenomas, and then to carcinoma, and then other changes are associated with metastatic disease. Anyway, this process of going from normal to cancer usually takes 10 to 15 years. And the reason why there are preventative screening tests for colon cancer is that we can intervene in these stages where there's adenoma and not yet cancer, and therefore hopefully prevent someone from ever going on to colon cancer. So there are different types of colon polyps. There are some polyps that have no malignant potential, and those include hyperplastic polyps. There are several different polyps with malignant potential: tubular adenomas, villus adenomas, and sessile serrated lesions. And then when you're talking about what we consider advanced lesions, that's any adenoma or sessile serrated lesion measuring at least 10 millimeters, lesions that have villus histology, or lesions that have high-grade dysplasia. So sort of finding and removing these especially can be very helpful. So here was a recent study published in the New England Journal of Medicine Evidence about colon cancer screening, approach, evidence, and future directions. And again, kind of just to review that all screening programs do have potential benefits, but as well potential burdens and harms. Some of the benefits include hopefully improved prognosis for someone who has received a diagnosis early, that they may be amenable to less invasive treatment, and reassurance for those with a negative screening result. But some of the burdens and harms is that some people who are diagnosed, it may not really change the overall prolonged prognosis and actually prolong life with reduced health. There can be overtreatment, including adverse effects of procedures, including those who are undergoing evaluation of a false positive screening result, or finding a precursor that without treatment would never have developed the disease. And we do know that probably 30 to 50% of those over age 50 will develop at least one adenoma in their lifetime. But as I already discussed, only 4% of people develop colon cancer. So there's many adenomas that likely would never go on to progress to cancer. So perhaps removing all of these small adenomas during colonoscopy is a form of overtreatment. There is also false reassurance for those who get a false negative screening result, and then negative effects for a false positive screening result, like a lot of worry and anxiety. Now, the initial screening studies that did show benefit in reducing colorectal cancer incidence and mortality were comparing non-invasive fecal occult testing, which was called guaiac testing, that versus no screening, or flexible sigmoidoscopy versus no screening. And in all of these models, if you got a positive screening test, that would trigger a full colonoscopy. So again, if you're talking to a patient about undergoing any type of screening test, they have to be willing to get a colonoscopy if the screening test is positive, because that is where the full diagnosis and perhaps prevention comes into play. And so again, an early detection screening test would be like the stool testing. And because you're testing more people, you may actually see an increased incidence, but there have been studies that clearly showed this resulted in decreased colon cancer mortality. And with the positive fecal tests going on to a colonoscopy, it does depend on the number of people who agree to that. And then we can consider our endoscopy as a preventive screening test. And hopefully there will be decrease in incidence and a decrease in mortality. And here were some of those landmark trials summarized, the data. And you can see that with sigmoidoscopy versus no screening, that the odds ratio for incidence was 0.78, and it was even greater if you're talking about just the distal colon, which is what the FLEX-SIG examines. And there was also decreased mortality. So that if you had no screening, your incidence per 1,000 would be 26 colon cancer cases. And with sigmoidoscopy screening, you'd have 6 fewer colon cancer cases and 2 fewer deaths. The fecal occult blood testing, some of the studies were done with every 2-year testing, and one was done with annual. And you can see here that, these data here is out to 30 years, that the incidence of colon cancer was decreased 0.81, and the mortality was decreased down to 0.68. So like 5 fewer cases, 3 fewer deaths. The keys to success with the fecal occult blood testing is serial testing. So yeah, you can't just do it one and be done. You have to do it every 1 to 2 years. And you can see that in that Minnesota trial, which was the big US trial, that after 13 years, 39% who had it every other year and 49% of the annual testing groups were detected, those who had cancer. And in UK and Denmark trials, 27% of patients who developed cancer were detected. So what about FLEX-SIG? It has some pros and cons. Pros, this could be done in an office setting. It can be done with just a few enemas as a prep. It can be done unsedated. It is less expensive and therefore cost effective. And the mortality from distal colorectal cancer was reduced by 40 to 50% in randomized controlled trials. What are some of the cons? Well, 40% of colon cancers occur proximal to the splenic flexure. 75% of proximal cancers do not have a synchronous distal adenoma, and sometimes patients cannot handle like the discomfort, or the prep, if not sufficient, can limit the exam. So what about colonoscopy? And this took off in the US in about the year 2000, when 2 publications in the New England Journal came out in support of this. So again, a FLEX-SIG usually goes up to the splenic flexure right here. But on a colonoscopy, we're going all the way over to the ileocecal valve and appendiceal orifice. The pros is that it's in a single session. You would be diagnosing and treating polyps, or, doing polypectomy to hopefully prevent cancer. It does have a higher polyp detection rate. And again, 40% of colon cancers do occur in the transverse or ascending colon, and many of those don't have a distal adenoma, which again, I was mentioning that a FLEX-SIG, for a FLEX-SIG is a screening test to trigger the full colonoscopy, it would be that you found some adenomas here on the left. It is the most expensive and it has the highest risks, and sort of large scale randomized trials about what its impact on incidence of mortality are still ongoing. And here is a little information about some of the risks, which the main risks are bleeding and perforation with a colonoscopy. And again, here with no screening, you would have 0 risks, but once you start doing colonoscopy, you start seeing a couple more bleeds or perforations. We usually quote that the rate of perforation in colonoscopy is about 1 in 3,000, and the rate of bleeding is 1 in 600. Other rare complications are infection, splenic injury, and then if someone is getting sedated, there can be adverse reactions to the sedation as well. And then here is a little example of like how this different screening strategies work. So your first round, like you could choose, you and the patient could decide they want to just do the non-invasive fecal testing. And if there's no blood in the stool, then the second round, which would be a year later, if you're using stool FIT, you do it. And again, if it's no blood, you repeat in 1 to 2 years. Yeah, I do want to mention that FIT, which is fecal immunochemical testing, has pretty much supplanted the FOBT because it does have higher sensitivity and specificity. It checks for globin and can be quantitated. And so different sensitivity levels can be set, but it reduces false positives that non-human blood, like say animal blood, would be detected. It does pretty much just detect blood from the colon and not the upper GI tract. And that is about $15. So that is like the least expensive screening test out there. If your fecal testing was positive, then you're going to send the patient on for colonoscopy. If you choose endoscopy, whether that be flex sig or colon, if it was flex sig and you saw polyps, they'd be going on to colonoscopy. For no polyps, again, down in the second round, and whether colonoscopy is picked up front or you get to it by any of these other screening tests first, then you have no polyps, low risk, high risk, or cancer. And depending on the type of polyp found, then we move into a surveillance strategy. Now, not all organizations can agree on what they think is the best screening guidelines and recommendations. But I'm going to show you here the United States Preventive Services Task Force recommendations, and the American Cancer Society is pretty similar. And these came out in May of 2021. They said that there was great evidence that adults aged 50 to 75 should be screened, all adults, for colon cancer. What was new 3 years ago was that they recommended that the screening age be dropped to age 45. And again, that is in response to the recognized increase in early onset colon cancer. And they gave that a grade B. And then grade C, meaning the data is not quite clear, that age 76 to 85 should be very selectively recommended based on what is their overall health, prior screening history, and patient preferences. And who does this apply to? Again, has to be asymptomatic and average risk. So what we mean by average risk is that they didn't have a prior history of colon cancer or polyps, no inflammatory bowel disease, no personal diagnosis or family history of the known genetic disorders, such as Lynch or FAP. And what could you offer? So the tests that the U.S. Preventive Services Task Force say you can offer would be high sensitivity guaiac or FIT every year, the stool DNA FIT every 1 to 3 years, a CT colonography every 5 years, flex sig every 5 years, flex sig every 10 years, plus annual FIT, or colonoscopy every 10 years. So these are all options, and you need to discuss it with your patient about what are their preferences. But again, you have to tell them that if any of these show a polyp that then or are positive, they are going to, you're recommending they get the full colonoscopy. Now, interestingly, 1 year ago, the American College of Physicians, which is the large internal medicine group, did not feel that the age needed to be dropped. So they wanted to stick with just start screening at age 50. They also said stop after age 75 or in any average risk adult whose life expectancy is less than 10 years. And what they considered options would be the FIT every 2 years, or stool guaiac every 2 years, colonoscopy every 10 years, or the flex sig plus FIT. Flex sig every 10 plus FIT every 2. They did not feel like you should be recommending CT colonography, any kind of blood test, or stool DNA test. What does Medicare cover? So Medicare will cover a screening colonoscopy once every 120 months. But if you're in a high-risk group, say you've had chronic ulcerative colitis for over 10 years, or you do have a known Lynch mutation, they'll cover it every 24 months. And then they will also, if you have a non-invasive stool-based screening test, it will cover the follow-up colonoscopy. They will cover fecal occult blood testing every 12 months, flex sig every 48 months. They still are saying they would cover a barium enema. And they will cover the multi-target stool DNA test once every 3 years. Now, interestingly, it says that you should only have this test if you're average risk, meaning that you don't have a personal history of adenomas. And I will tell you, I've seen several patients recently who had a Cologuard positive that I look back and, they had a prior adenoma, say 10 years ago. So I'm not sure why, the primary care doctor recommended that as a screening test. It really should be average risk patients. And they said they will start covering blood-based biomarker screening tests, again, every 3 years with similar conditions. Oh, I see that we're running out of time here. So let's just quickly go through a couple of articles that were in the March New England Journal. One was on the next generation stool DNA test for colon cancer screening. So the first stool DNA test was FDA approved in 2014, and it had a fairly high false positive rate. So the goal of this new test was to improve specificity without losing sensitivity. And they picked a commercially available FIT test as comparator, not the currently available Cologuard. And they did find a slight increase in overall sensitivity, which was better than FIT. But actually the specificity was not better than FIT testing. It did have a sensitivity of 43% for advanced adenomas. And among those with a positive result, you can see that no polyps were found in 30%. So that's where, the people who have the Cologuard positive, a lot are going to be very worried, and about 30% will have nothing found. Okay, and then in that same New England Journal was this paper about cell-free DNA blood testing. Of course, many people think that's going to be like the Holy Grail. Just send someone for a blood test. It was the Eclipse study. The product is Shield by Guardant Health. And they found 83% sensitivity for colon cancer, 90% specificity, but unfortunately only 13% sensitivity for advanced neoplasia. Let's skip through that. Here are the numbers I just gave you. And here's like a little summary table of the two studies versus FIT. And where you can see the next gen stool NA does have decent sensitivity for advanced adenomas. What CMS says it will cover if the test achieves 74% sensitivity, 90% specificity, and gets FDA approval. Just on May 23rd, the FDA's Medical Devices Advisory Committee voted 8-1 that it was safe. 6 of 9 said the test appears effective. 7-2 voted that it benefits outweigh the risks. They recommended using this as a second line option, and the final FDA decision is still pending. But some people have weighed in and quote unquote call this like a liquid biopsy. You can see here that 60 to 70% of Americans are getting screened with a variety of tests, but there are still 30 to 40% who are eligible that have not been screened. If the liquid biopsy increases the CRC screening pool, it needs to be better than not ever being screened. But to replace one of these existing tests, it needs to be as effective as FIT. And the experts felt that compared with no screening, it would be cost effective. But for it to, but currently, with the current data we have, it is not as effective as our other screening tests. And to shift the screening strategy, it would need at least a 70% sensitivity for advanced lesions and cost $140 or less. So currently, blood tests should not be recommended to replace our established screening tests. When to stop, screening should cease in patients with less than 10 years estimated survival, when the risks outweigh any potential benefits, and when tests are unlikely to prolong patient survival. And surveillance is generally not necessary in anyone over age 85. There are the references. And so, yeah, if we don't have time for all the questions, certainly you can email me.
Dr. Gangarosa, thank you so much. This has been a really packed presentation. We are very appreciative. And we do have questions. I've got several. I'll go ahead and start posting them. The first one, are there disparities for un- or underinsured versus the insured?
Yes. I don't have all the figures in my head, but obviously if someone who has poor access to getting screened, or what happens, I'd say more often, is maybe they do get the stool test and then they don't go on to get the follow-up colonoscopy. And so, yeah, we do have to work on reducing those disparities as well.
Thank you. Why is surveillance a wide range for 5 to 10 for low risk versus 3 to 5 for high risk versus more specific dates to return?
Yeah, so that would be like a whole different talk. But okay. So in general, if someone has no polyps or just hyperplastic polyps, we say 10 years. The current guidelines say if you had 1 to 2 small tubular adenomas, meaning less than 10 millimeters, you can say anywhere from 7 to 10 years. Again, because we're not sure that these really small adenomas ever go on to do much, and it takes a long time to go from normal to cancer. Whereas if you had 3 or more polyps, well, now we say 3 to 5, again, small, maybe you would tell that person 5 years. And if you had any polyp with the advanced features of like greater than 1 centimeter or villus or dysplasia, they're going to be coming back in 3. And you might even up it to, if someone had more than 10 adenomas, you'd have them come back in 1 year. Or if you felt you had to, like what we say, piecemeal remove a large polyp, you might bring them back sooner to make sure you really resected it all. So yeah, surveillance is a lot more complicated.
Gotcha. Well, thank you for talking about that for a bit. And I just want a big shout out to our audience. We love our audience. They thank you for all the questions that are coming in, and we've got several more. Any data on delayed diagnosis / treatment due to COVID, post-COVID catch-up? I know this is a question around a lot of different areas of cancer.
I mean, I think it's probably true, but I don't know. Again, I don't know the numbers. So, right, we obviously during 2020, we stopped doing like elective things for many months. And so, and then it was just the next year that USPTF said start at 45. So, I mean, we really do have like quite a backlog of trying to get people in for screening, partly due to the COVID and partly due to the lower age.
Gotcha. Thank you. If a 34-year-old white male patient has an 18-year history of ulcerative bursitis, do you recommend yearly flex SIGs or every 3-year colonoscopies as long as they're in remission?
So, yeah, that would be somewhat nuanced too, like in terms of like, are they really in complete remission and do endoscopically things look normal? You probably can space things out a little, but if there's any inflammation, you're going to maybe be doing it more often. And yeah, I mean, obviously the limited disease is less of a risk than pancolitis. So that would also be somewhat nuanced.
Okay. All right. Thank you. I know there's I remember hearing years ago a British physician talking about some of the advantages to being unsedated for a colonoscopy. So what are your thoughts on that? Colonoscopy sedated versus unsedated without any other complicating factors?
I mean, I do feel that if you go unsedated, you are removing the risks related to sedation, which can be a greater risk of aspiration or, rare cardiopulmonary events with anesthesia. But, a lot of Americans are very, I don't want to say wimpy, but, let's say they have a low pain tolerance threshold. So, in those individuals, having some sedation may make the exam safer for them because they're like, it would be too uncomfortable during the test to hold still and for the doctor to, get a good exam. But I mean, I've done plenty of patients unsedated, and I think it really depends on the patient's, pain threshold.
Gotcha.
In Asia, in Asian countries, many more people do it with minimal to no sedation. I think they're more stoic.
Well, we are over time, so we'll go ahead and let me give one question to close. As somebody who's done both the PrEP and the unsedated, I will say I think the PrEP's worse than the unsedated colonoscopy. Do we see any hope in the future that the PrEP for colonoscopies is going to get any better?
I mean, we do now have some lower volume PrEPs available. We do have one approved tablet only PrEP, though again, you have to not have any history of renal disease to be eligible for that. Insurances may not cover some of these preps that are a bit more expensive because they're newer, but definitely they are options for people to try. There are several lower volume ones available now.
All right. Thank you so much. Well, we really, really appreciate this. Again, I'm sorry we can't get to all the questions. We are out of time. We want to say thank you. The funding through the people of the state of North Carolina, to the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to say thank you to our team. That's Benny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, and Barbara Walsh. There are hundreds of steps involved with each of these lectures, and each one of those people plays an important role in this lecture series for each and every one of the lectures. Thanks to Don Poe for writing our music, Back Roads. We want